Hey!
Thanks for coming tonight. It's great to see all of you here eating. And there's more over there, so keep eating. We're going to go ahead and start anyway, just so you can use all your senses. First, I'd like to present Dr. Patton. He's the medical director of the Rand Schrader Clinic. It's the largest HIV practice in LA. They have about 3,000 patients and probably counting. He oversees about 30 physicians. He has 20 years experience in this field. And most importantly, he's on the board of directors for Sedell Wellness Organization. Also making a presentation tonight is Dr. Sada, right here. You better clap for him. He's Dr. Ken's right-hand man. And he's also at the Rand Schrader Clinic. He's one of the top physicians there. He's also the lead physician at the Early Intervention Clinic on Skid Row, which is one of the demographics we're trying to reach out to. In addition to people of color, Hispanics, African American, where unfortunately the epidemic is hitting hardest right now, and then mental sex and men. But we take care of everybody here. At Sedell, we try to integrate Eastern and Western practice to provide a holistic approach. So it's one thing for the physician to write you a prescription, but then you must have the self-esteem that you care enough about yourself to take the medication. And then by taking the medication, you reduce your viral load and reduce the transmission to other people. So we can help not just you, but the whole community that way. We're providing a safe space here. You can come in here, let go of stigma, let go of judgment, and eat a lot of food. So keep eating and have a good night. I'm so glad you all could come. We can have you sign up for programs here. We have acupuncture, chiropractic, Reiki, reflexology, yoga. We're starting a new dental clinic, probably in a week or two. If you want free dental care, basic care, go ahead and sign up here. We can put you on our list so you can get an appointment when we're ready to move forward. Yes, Patricia.
Hello everybody, my name is Patricia. I've been working here since Friday, this Friday, coming. But I only want to ask if you can please turn off the cell phones for the presentation.
Right. Thanks, Patricio. Yeah, Patricio is going to be our mental health specialist. He's now a licensed a therapist, but in Chile, right?
Yeah.
And he's taking his master's right now at Antioch. He'll be a full-blown therapist here. But he's going to be starting support groups, one-on-one counseling. If you have need for that, you can get in touch with Patricio. We have optometry here, an arrangement. We collaborate with Dr. T-Vision. If you need that. Anything else about? That's pretty much it. If you need anything specifically, let us know and we'll try to get it. Oh, we have CPS, which will help you if you need help with benefits, Social Security, disability, Medicare, Medi-Cal. You know, we have to re-enroll in AAP every year, and it's going to be moved up to every 6 months now. But the period in between birthdays will be by mail. I guess it's a little easier. But they can help you get your ADAP enrollment appointments before your birthday. They can help with just housing, anything else you might need, so you don't have to go through all the legal quagmires. All right, I'll turn this over to Dr. Ken so he can start with his presentation. Thank you.
As Gene did mention, I'm on the board of directors, but this evening is also a co-sponsored event by another organization that I'm also on the board of directors, another nonprofit, Hollywood Remembers. And before we get started, I'm just going to ask Ted, one of my colleagues from that board, just to tell a little bit about what Hollywood Remembers does and how you all can maybe even be helped by it.
Thank you. Hollywood Remembers is a nonprofit organization, and if you look at the name Hollywood Remembers, well,
Hollywood remembers those who have gone before us with HIV and AIDS by service to those in the community who have HIV and AIDS or are at risk. We have partnered with CPS and CDL to referral, workshops, various organizations, trying to help anyone who needs it. And if you can be of service, if you want to volunteer some way, shape, or form, we might be able to do referrals for you and get you in the right places. But advocacy and education is the primary source of people staying out of trouble and staying out of HIV and AIDS, and also to prevent them from getting AIDS and preventing others. So we're there to provide services to you and help you wherever we can.
Some of the information you're going to see tonight is probably very familiar to everyone, hence the idea of familiar information, but some of it's going to be with a new bit of a spin, so with some newer information added to it, or perhaps we can reflect on it in a different way. Let's go back. Just in case there are questions that come up, I'm happy to take them as they arise, or if you want to hold them towards the end and ask them that way. Or if there's something that needs clarification on it, just feel free to blurt it out, raise your hand, however you feel comfortable in asking. So maybe you can let them know that I just said that.
Para las personas que no entienden muy bien el inglés, si tienen alguna pregunta, hay algunas copias yo en español y en inglés sobre la misma presentación. Así que si tienen alguna pregunta, hagan la pregunta, yo hago la traducción y el doctor responde la consulta.
Couldn't have said it better myself, thank you. Okay, first slide, please. Okay, so what is HIV? Again, HIV stands for Human Immunodeficiency Virus. Human because only humans can get it. Some of this is going to be a little simple, but it plays into what we go into. Immunodeficiency means that the immune system, which helps the body fight, defend against infection, is adversely affected and is weakened. And virus because that's what it's caused by, a tiny little particle that may or may not be alive that infects cells that then invades them and takes over their ability to replicate and hijacks the entire body. Next slide. So you hear about that a lot, and a lot of you are probably very educated on HIV. But some things that doesn't get discussed much is where did it come from? I mean, there's a lot of stories out there, but this is what the science tells us. Well, HIV came from our ape relatives, our primate relatives, chimpanzees and gorillas. It's very closely related to a virus they've had in their network for centuries called SIV, which is Simian Immunodeficiency Virus. So what we believe is that this virus gave rise to the two types of HIV that are predominant in the world. HIV-1, which is the one that is most responsible for the epidemic across the world, and HIV-2, which is a lot less infectious and problematic and isolated to just very specific areas of Western Africa. Well, this virus was existing in nature for hundreds and hundreds of years, but we believe that it made the jump from gorillas and chimps to humans about 100 or 120 years ago. This is put together through molecular modeling, identifying how quickly we understand the virus to mutate, and looking actually at samples from people who have died at those ages and replacing it. We believe it made this jump from primates to humans because of a thing called bushmeat practice. If you don't know what that is, it's basically what it means. The animals that are in the jungle, bush and brush, are basically hunted for food. So some of those happen to be chimps and gorillas and other monkeys carrying the virus, so it's believed in the hunting process. If you've ever skinned an animal, it's not a very clean thing to do. You can easily contaminate, you open a wound, and we believe that's the way the virus got into the human circulation. For the most part, this stage largely contained in rural Africa for decades or even a century or so. And it wasn't until there was large urban spread, and we believe in some widespread vaccination efforts, outbreaks of genital ulcer disease, and even the practice of female circumcision, all these things coming together that allowed it to spread into urban areas. Urban areas more populated, easier for any disease to spread. And then modern technology came and we were able to traverse the globe in a day to two, and then we sort of had the spread of disease. Once in the urban population, it was only a matter of time that it would spread across the world. But what was it that we encountered? This was back in the 60s and 70s when it was breaking into the population. We didn't have the technology nor the ability or even the knowledge or even to identify ones finding viruses. What we were faced with was, next slide, the development of AIDS. So it wasn't a virus that we found, it was actually a condition. Next slide. AIDS is the most advanced stage of HIV infection because, as we'll talk, there's a big spectrum of it. Next. And it stands for Acquired Immune Deficiency Syndrome. Acquired meaning you get this from another source or another individual. Immune is the immune system which helps the body fight infection is affected. How is it affected? It's deficient, meaning it's weakened. And it's a syndrome because, next slide, it's a constellation of a set of symptoms that people get when their HIV has weakened their immune system to a particular point. So we were faced with this back in, well, for the United States, 1981, but if you go into Africa, even before, decades before that, they had a condition called slim disease, which was in and around many villages. People just basically wasted away. In retrospect, this turned out to have been HIV and AIDS in those instances as well. So, next slide. In 1981, this thing happened to hit the shores of the United States, and particularly 1981, in June of that year, the first cases were reported here in Los Angeles, and shortly thereafter, in a couple months, in New York City and San Francisco, and they were all in gay men. We're going to talk about how the face of the epidemic has changed, because back here it was basically gay white men who were about 35 years old. That was the average age. And if you were a gay white man at that age and you didn't have some kind of condition where you were sweating at night and you had large lymph nodes, people didn't believe you were a gay man. That's how prominent or prevalent this situation was. Just a little bit on the historic landmarks. 1981, when the first cases are identified. It wasn't for 2 years later that the virus itself was cultured. It actually took a very long time to do this because the virus was very tricky. They're used to this type of virus mutating cells and growing very easily, but this was killing the cells that they were trying to grow it in, making it more difficult. It wasn't until '85 when we actually had our first commercially available laboratory test that could find the antibody. Up until then, people were just being diagnosed by a constellation of symptoms like the large lymph nodes, the night sweats, fatigue, and diarrhea. '87 when we had the first drug approved to fight HIV infection, AZT, but it, along with all the other monotherapy drugs, were really not very effective at all. It was in '89 we had the development of guidelines to prevent pneumocystis pneumonia, which was responsible for making most people with HIV and AIDS sick or kill them. Very severe parasitic pneumonia. 1990, a very important year, Ryan White funds were allocated by Congress to provide money to give care to persons with HIV and AIDS. And this actually still exists today, and it's responsible for saving a lot of people's lives. But all of this was really just marking time, trying to keep people alive long enough for the next infection to kill them. It wasn't until 1995, 10, 15, 14 years after the onset, that the condition actually started to change. In 1995, we had the development of first medications that did anything to reverse the condition of the disease, the protease inhibitors, and that's where the concept of HAART, the highly active antiretroviral therapy, was. Prior to this time, and I remember it very well because there was a medical school right around here, and residency all through here, things were really pretty dire. We would not invariably have a night shift in the hospital, and where I would have to probably pronounce 2 or 3 guys in their 20s or 30s dead because they died of complications of AIDS. So that's what my residency was all about. In fact, I used to think, what was this hospital admitting before we had HIV? Because this is all they ever admitted. Was it even in business? Where were the little old ladies with heart failure? So they were there, but they were lost in the mix, right? So protease inhibitors really changed things so as within a matter of 1 or 2 years, we saw the number of AIDS deaths plummet. We, in fact, where I did residency in New York City, we had to close our inpatient AIDS unit. That's how much it positively affected healthcare. And then things were really, they may more or less maintained that kind of a stride. And I just throw these 2 things in at the end, the approval of ATRIPLA and the quad pill. Not that there's anything special about one or the other than the fact that we moved from making many regimens of medications from a dozen or more pills a day to 1 pill a day. So that revolutionized a lot of things because it brought care to situations where persons might not otherwise be able to tolerate a lot of medicines or coordinate a lot of medications. Next. Just graphically, and this never appeals to many people, but it does drive home a point. You know, in the before time, before heart, we were dealing with lots of opportunistic infections, and all the common ones, which was tuberculosis-like organisms, pneumocystis, CMV, toxo. The incidences were all very, very high, but they started to drift off once we got the highly active antiretroviral therapy, and they've continued to plummet ever since. This is what's really kept people healthy. Next. Very, very busy slide, but basically, I'll talk you through it. You get infected, the viral load goes up, T cells start to come down, they start to win a little bit, and all of a sudden the viral load ticks away for a little while until your T cells eventually wither down enough to as the virus starts to win, and you get opportunistic infections. And unless something happens like antiretrovirals, you're into care, and then you can probably die. All along, and this is just data from 2007, 2010, because it was as easy as just to pull off the web, but it's basically what the stats have always looked like. Males have always been disproportionately affected over females in the United States. If we were to look at data from a different country, from say Uganda, these would be very much closer together. In fact, they would always be superimposable, with actually females being a little bit more affected than males. But males are always disproportionately affected in the United States. Next. And specifically, the risk factor, those disproportionately affected are males who have sex with men. So whereas this started as a gay man disease, it's still statistically a gay man disease, but the face of the gay man has changed from a gay white man to now a gay man of color. And we'll talk about that shortly. The heterosexual transmission has been relatively flat, and injection drug use and men who have sex with men and who also use drug use have always been on the lower end and pretty steady. Next. So if you look at transmission and you want to look at risk categories in males and females, just to see how transmission categories affect each group. In males, by and large, male-to-male sex contact is the winner. For females, 86% heterosexual, 14% the injection drug use. And for males, by far and away, over 3/4 men who have sex with men. Next. Looking at race and ethnicity drives home one disparity. The other disparity is ethnicity. In males, 41% are black or African American. What's the percentage of the American population that's black or African American? Like 14%? Okay, so look how disproportionately this is affected. And 24% black, Hispanic or Latino. This is a little bit closer to what the demographic is in the United States, but it's still overly represented. I think the Hispanic population is around 17%. So it is a bit closer. But if you look at it, way disproportionately represented. Females, just the same. In fact, for African American women, even greater, 62%, 18% for Latina, and 17% for Arab. 70% of the American population is Caucasian. Those are disproportionately they're represented now. That speaks to a whole lot of issues that we don't necessarily have time to go into tonight. It can be the point of future discussions. Next. And then I want to go about 30 minutes, so let me know how that. What, I'm already over time? Next slide. So what do some of these numbers look like locally? This is 2010 data. I put this slide together for a talk at the end of last year. We're always 2 years behind. We're just starting to get 2011 data. It looks a lot similar to what this is. This is just to give you an idea of Los Angeles County versus California, United States, and the number of new cases. On average, number of new cases each year of HIV infections in Los Angeles, 2,000. It's running about the same for 2011 as well. Other years have been a little bit higher. California, 4,000, 5,000, 35,000 for the United States. The United States usually averaging around 50, 55,000 cases of HIV or AIDS annually. Of course, the number of people living with HIV or AIDS is getting larger, and that's actually a positive statistic because it's keeping sick people, making them well, and they're living longer. Excellent. Just another slide to show you that number of AIDS diagnoses, they also decline. Why did they decline? Because we intervene early so as people don't get sick enough to qualify as a diagnosis of AIDS. don't let the immune system get taxed that much. Next. Persons living with AIDS by rates of ethnicity also continuing to grow. This being moved back here, we're across this representing the virgin sin where the epidemic is disproportionately affecting African Americans. Next. So now that we talk about where it spread to, let's talk a little bit about the routine things of HIV and how it spread. It's mainly spread through exchange of body fluids. That's not brand new to anybody. What does that really mean? That means having unprotected sex, vaginal sex, anal sex, oral sex, not using a condom, and actually now protective sex is going to take on another dimension when we talk about pre-exposure prophylaxis as a component of that as well. We're not going to do too much of that tonight. Not every county hospital can make that. Not every hospital can make that claim, but it's mostly because how quickly you can get a woman into care, tested, and put on medication. Next slide. Is there a question?
Yes, the breast milk, how is it that the baby gets the HIV by...
The virus is in the breast milk as much as it is in, say, semen or blood.
Yes, what happened to the baby? Does the gastric juice and stuff store it?
Well, the baby doesn't have a very intact GI tract. There's a lot of openings, and it's got a very weak immune system, and there are aspects that it doesn't have a lot of antibodies that could protect it. So it is a vulnerable state.
But the adult get it, or seems like compared to an adult getting oral.
Well, I think you're talking about having oral sex?
Yes, and if they're seeing they swallow.
Right. Well, in all honesty, it's probably, you're in a lot better off position as an adult than as a baby. If you have an intact integument mouth, it doesn't have any ulcers, you have a gastric acid, it'll likely not allow it to be infectious. The actual infectivity rate from oral sex without someone who doesn't have oral ulcers is really very low. It's not zero, but it is very low. And when you talk about that in the setting where people are on medications and their viral load is very suppressed in the semen, it gets even lower. So clearly when you talk about sex, anal receptive intercourse is the highest. Moving on. And this is called preaching to the choir because you all know how it's not spread. Next, just hit it a couple of times. It's not spread by air or water. Insects such as mosquitoes, saliva, tears, sweat, feces, urine, no casual contact, shaking hands, sharing dishes, or closed-mouth social kissing. We know it's not. Yet I have patients whose families were really concerned that they want a letter from me saying that they can eat off the same dishes.
Wow.
This day and age. Very, very tragic. And it is true, yeah. Next slide. So now we talked about how it's not spread. We talked about risk groups. This is actually, we're going to go a little bit into a specific aspect of transmission, or a specific aspect that plays into transmission, but also into overall care, and that has to do with drugs and substance abuse. This is actually a picture from a poster in, I remember seeing it when I was in medical school in New York City subways. This was actually advertising to protect yourself from using drugs. Don't use IV drugs, otherwise you're going to put yourself at risk for HIV. So we're looking at a man who's, I can't read what it has to say, but basically the point is, why are you going to jeopardize all this by dabbling in drugs? So yes, we know the method of just say no always works, and probably saved him too. Moving on. So substance abuse and HIV next. So in this, we're going to talk about drugs in general, but in substance abuse, they're going to have a very broad context. From tobacco, any type of drugs, whether it's prescription or recreational street drugs, and regular old alcohol. Next. Substance abuse affects adherence to HIV medications. We're going to talk about substance abuse and substances of abuse and use, in how it plays not only into HIV transmission acquisition, but also in how it plays into general health and well-being, regardless of whether it plays into transmission. Next. Basically, things we're going to talk about can have widespread effect on just about any organ of the brain, and we're going to touch on them if we have the time. Next. So, tobacco. You didn't think I was going to lead off with that one, but tobacco is the most commonly abused drug bar none, no matter where you're looking in the United States, but also in our HIV population. Next. Now, it may not have anything to do with the acquisition, unless, of course, someone is really jonesing for a cigarette and they're willing to trade sex for it. I'm sure that's happened too. But it's not the most likely method of acquisition. But once infected patients who have HIV are somewhere in the order of 40% more likely to smoke than people who are not HIV infected. I don't know if we know the answer why. But smoking basically can harm just about every organ in the system, from the brain, causing stroke and vascular disease, mouth cancer, throat cancer, in addition to bad breath and yellow teeth, lung disease, lung cancer, heart disease, kidney problems, stomach problems, colorectal cancer, bladder cancer, and osteoporosis and bone thinning. Next. Like I said, people with HIV are more likely to smoke than the general population, upwards of 40%. People with HIV, smoking is linked to an increased rate of death. True for current and ex-smokers. And then it can get into other reasons that HIV contributes to other metabolic conditions that seem to increase your cardiovascular risk. And the greatest risk is from an increased risk of heart disease and cancer, the greatest risk of death. Next. More likely to develop pneumonias and infections like thrush, mostly because it irritates the mucosa and damages local parts of the immune system that keep your lungs clear. Next. Quitting smoking, very important. So if you haven't tried, talk to your doctor about it. There are numerous ways you can go about it. There's medications there's medications to talk about. There's Chantix, it works very well. There's quitting programs, there's nicotine patches. There's even 12-step programs called Nicotine Anonymous that can actually work too. All depends on your particular bent and how you want to approach it. But here's some general information, but I think if you are smoking, your doctor should be on you about not smoking. And if your doctor smokes, you should be on him or her about stopping and get you to stop as well. Some doctors do smoke. I don't. Do you smoke, Dr. Stone? Okay. Cigars, he says. Next. Okay, so into the other drugs. Next. These are the things that probably more likely to involve both acquisition of HIV and screw you up and getting well too. So we're going to talk about things like cocaine, heroin, marijuana, the street drugs. This is a borrowed line. I don't like the word illicit. It's judgmental. That's not me. But I use the term recreational for persons. Prescription medications. These are things that the doctor gives you for your back pain. Not unheard of. Very easy to get hooked on. In fact, it's one of the growing areas of addiction. Pill poppers, they call them. And everything from codeine, morphine, opiates, oxycodone. And over-the-counter things like cough syrup, inhalants, pain thinner, gasoline. These actually have the greatest propensity to do immediate brain damage, inhalants do. Just after a few times huffing, you throw somebody in a PET scanner or a functional MRI, you already see holes popping up in the frontal lobes. Not very hard to do, turn somebody into a basket case after that. Next. We're going to talk about here. So, as you may know, people take drugs for all kinds of reasons. Usually it's to feel good, because that's what a drug is there to do, right? So, but it's really, so that in itself is not necessarily harmful, bad, or anything else. It's just what comes after that, or what it may lead to as a standard practice or habit. Overuse can actually cause all kinds of problems in your ability to care for yourself. It eventually can get to the point where homelessness, it winds up widespread addiction. You're selling drugs to make money. HIV comes in there because it's very easy to have unprotected sex on some of the drugs we're going to talk about. In fact, that's the preferred way. So there's a whole bunch of things that come with it, and eventually winding up in severe morbidity and mortality. Next. A little bit about cocaine. Cocaine is very highly addictive, especially if smoked as crack. Side effects of cocaine: increased heart rate, body temperature, blood pressure, stomach pain, nose, throat problems, cause ulcerations in any of those areas. Next. It can actually cause sudden death from a heart attack or stroke. Also, cocaine, like meth, which we're going to talk about shortly, probably one of the most common drugs to be associated with unsafe sex, unprotected sex, easy to spread disease or any other sexually transmitted disease. The other thing that doesn't get mentioned too much, there's nowhere on these slides, is actually Very early on, cocaine was actually identified and noted to increase HIV's replication. So this was actually studies that were published in 1991. I remember reading them as a medical student. And they took peripheral blood and they actually exposed it to, well, actually they took people that had enjoyed cocaine and they took their peripheral blood, and what they noticed is that those who were able to, where are they now? I don't know. You didn't want to be in the placebo group for that. You would love this. What they found is actually increased their HIV replication. It does this through a very complex way of signaling in the virus. So that's another thing that sometimes doesn't get discussed very much. Next time. So in addition, and actually we're going to cover some of this in when we talk about methamphetamine, because it really does it also very, very significantly. Decrease your ability to adhere to HIV medications, which basically, you know, if you're off with them for any period of time, the virus has a really good shot of coming back. Next. So methamphetamine, probably the single most important drug on this side of the country to fuel the HIV epidemic, especially in gay men. Mostly because it does everything you need to fuel sexually transmitted disease. It gives you lots of energy, increases your sex drive, and screws with your frontal lobe so fast that you're having sex before you even know it. And you don't even know it because it turns on all the neurotransmitter in your brain that says, hey, things are fine, drop your pants. It was, you know, more or less designed to do that. So, so it just basically has been very, very effective in fueling the epidemic. Next. Costs of long-term meth use. Long-term meth use can lead to changes in the brain, memory problems, confusion, difficulty understanding new information, both while using meth and for extended periods of time coming off and recovering from it. Also cause extreme weight loss, dental and skin problems, anxiety, sleeplessness, mood swings, violent behavior, and so on and so forth. Next. People with HIV, meth use is going to be a serious problem because I think of any drug, this probably can interfere with one's ability to make good decisions for oneself. And until single tablet regimens came along, someone actively using meth, I rarely considered putting them on medication because the time, you know, it would be very, very difficult, if not impossible, for them to measure out every 8 hours which pill would be when and which pill shouldn't be when. So it was very hard. Single tablet regimens really revolutionized that for my practice because even persons who are actively using can actually adhere to at least that much. And you do a good, and I think it's actually particularly helpful in situations like that because this is the group that will continue to be at risk and expose others. So if you can if you can drop their viral load significantly to other type, you're going to do a lot for in the public health thing. Next. Like I said, persons with HIV who still abuse drugs can be treated. We got to kind of take them on a case-by-case basis. Sometimes it's better just to wait. Sometimes someone might be sick enough that we can't get to throw them on something and kind of hope things come together. So a lot of very active case management there. Many cases, the best thing to do, like I said, is address the drug abuse. Sometimes it's easier said than done because addiction is a very complex process and medical problem in itself. Next. Okay, good old alcohol. So, next slide. Also very, very widely used or abused drug. You know, it's always difficult with legal drugs when they cross the line from use to abuse, right? You're also going to probably more likely find a lot of more functional alcoholics and stoners, for example, than you will functional cokeheads or meth heads. So that's why it makes this alcohol a little bit more difficult to tease out. You also can't give somebody a urine toxicology test and say, aha, you drank alcohol last night. It's not that easy. And if they did, so what? I was at my uncle's graduation or whatever. It's finally gotten out of night school. So, but what is alcohol use considered normal, and when do you deviate from that? It's very, very difficult. In the medical school, they taught us the way you ask if someone is drinking. Okay, how's this fun? You know if someone is drinking abusively or overdoing it when they drink more than you do. So you always ask, what drinks did you have last night? 7? That's fine. I had 8. Has to do with, we're also taught the same rule of thumb with sexual partners. So anyhow, but that's a topic for another time. All right, so what's moderate alcohol use? It's defined as, and actually they raised this, it used to be less than this before. So, up to 1 drink per day for women, but no more than 3 drinks in a single day. For men, 2 drinks per day, but no more than 4 in a single day. And this is your typical category of what to drink. And you go to a bar, there's no way in heck that this is representative, right? I mean, 1 martini at the Abbey has got at least 3 of those, but it's $30, right? Next slide. Harmful effects of alcohol eventually include, if you drink long enough, liver damage, high blood pressure, even if you don't drink very long. The alcohol is a sedative, but it actually is very easy at causing elevated blood pressure. Cancers of mouth, throat, and stomach, injury, violence, and death, obviously. Drunk driving, domestic violence, all that sort of thing. Of those who drink, 29% of U.S. adult drinkers report binge drinking, which is associated with a wide range of other health problems, including STDs. Actually, this is the type of alcohol abuse that is most commonly associated. Binge drinking, if you don't know what it is, it's when you may not drink every day, but when you drink, you sit down or stand up to drink, you drink a bunch just to black out or get that feeling, and then God knows what the hell happened. Next. Heavy alcohol use can cause problems with people with HIV, mostly because of the things we just discussed, because you're going to be drunk off your butt, you're not going to remember to take your medication, and eventually the damage that it does to the liver. Another problem we're not going to talk too much about, but hepatitis in this group of HIV can be a big epidemic problem. Hepatitis B or C can also damage the liver. You put alcohol on top of that, you greatly accelerate the damage that can be done. Next. So seeking help for this, if it is, next. Substance abuse treatment is often necessary for successful HIV management, especially when someone's got nothing together and they need to get a pull together to get them into treatment. What are you going to do? Usually, next slide. Start by talking with your medical professional. Not every doctor or provider is going to be comfortable, even knowledgeable, talking about addiction. So if that's not the case, either ask them if they can refer you to somebody who is, or you may need to find someone who, on your own, who's comfortable and knowledgeable about it. We don't cover it very well in residency or medical school. Next. Actually drugs of abuse and the whole issue of substance abuse is a big spectrum of conditions. It's not all people using drugs or alcohol in an abusive fashion are not all addicts. They can everything from problem drinkers or problem users to full-blown addicts and everything in between. It's a very complex situation. But when it comes to addiction, perhaps the best that we have to offer are inpatient, outpatient treatment programs that all incorporate a 12-step program. Personally, I wouldn't believe the advertisements you see that people have cured addiction. The American Society of Addiction Medicine does not recognize those processes that have been successful. I think there are great advances being made in addiction medicine in the recent years, and we're going to see really tremendous advances in the next decade or so. But right now, I think inpatient, outpatient treatments coupled with a 12-step program are probably the best you could really do for your patient or for yourself or a loved one. 12-step programs probably have the best success rate, which isn't all that good to begin with, depending on how you look at it. It's about 10%, meaning it's about 10% of people who try a 12-step program stay in recovery. But if you look at people who stay in a 12-step program, your success rates are 90 to 100%. So depending on how you look at this, but unfortunately that's all we're at right now. But I think the science will bring us closer, a lot closer in the coming years. This is just some resources to access for problems like that. Narcotics Anonymous or Alcoholics Anonymous. Thousands of meetings around the Los Angeles area. Next. And summary, substance abuse, which is an ongoing problem, can include everything from tobacco, which can be generally harming your health on a daily basis, to alcohol or methamphetamine, which can be devastating to you and your family. Substance abuse treatment is often necessary for HIV successful treatment, but we take that on a case-by-case basis. Any questions? Yes, sir.
Is there any pro to taking, let's say, like a 3 medicine regimen as opposed to like a quad?
A 3-medicine regimen versus the quad.
Yeah.
Give me an example of a 3-medicine regimen.
Like, taking Norvir, Rayataz, and Truvada, instead of just taking the triple.
Well, that's kind of a complex question. So, and beyond the scope of this place to answer, but what you want to do, I'll give you the principles we would follow in identifying which regimen someone would favor. First of all, people will come and ask you for a specific regimen. I want to be on a triplet doc. So you get, maybe the triplet will be a reasonable approach. You talk to them and they have a very severe history of depression, and that may not be a triplet for you. Or you get the genotype and it doesn't even look like it's usable. So then we might go to some other single tablet regimen, and we'll talk about whether or not that there are advances. But sometimes there are conditions that I may want to use a combination medication, not necessarily single tablet. So suffice it to say the answer is complicated. Anything else? Yes, sir.
Is there any related to the fact that toppling reduces reduces a lot less?
I think if you look at it that way, a lot of things go into that. Okay, so you're talking about, are we talking about a top who's negative or positive?
Negative.
Okay, negative top, having sex with a positive bottom. Is that positive bottom on drugs or not on drugs?
No variable.
An undetectable bottom. Okay, so those things together are putting things in your favor. Can't really say by how much, because these are really innumerable things, you know. So, but these are all things moving in the direction where it's better. Which actually brings us to the idea where treating people in the population to control the spread that's a specific aspect. Is your top circumcised or not? So circumcised. So we know that male circumcision decreases the risk substantially as well. In fact, it's actually considered to be a reasonable method in underdeveloped countries to do this.
And you're talking bareback as opposed to using that. It's still a risk using it.
Right, you know one can quantify the risk reduction? So, you know, you might move down a few notches in the percentage points, but if you use a condom, you're like 100%. Oh, so yeah, let me just throw that out there. You see some studies quoting condom success or efficacy in the 60, 70% range. That's BS. If you look back at the early data from the French studies back in the late 80s, early 90s, when there were no antiretrovirals, their rates of condom efficacy were in the 90 to 100%. So those are really the most efficacious. Yeah, and the only other thing you've got close to that is now people who are very adherent to pre-exposure prophylaxis. So I think I'm going to turn this over to Dr. Satan. He's going to...
Wonderful. We just want to reiterate, we are both so excited to be here. And thank you to Hollywood Rumors for having us to be on the board, and we're really excited to be outreaching to the community and speaking about HIV, because we know what an impact that can have on decreasing the stigma of HIV, as well as getting everybody kind of more knowledgeable about how it's spread and how to get a hold of this epidemic. So this is another great example of what we like to do outside the clinic, so appreciate you guys all for being here. There are several topics that I'm going to cover. I don't speak as eloquently or as fast as other can, but I'm hoping to get through the slides in a reasonable amount of time. And again, if anybody has any questions, feel free to ask as we go through them. Okay. Next. I already did it, so next. So main goals, obviously this is meant to be an open and honest discussion. And there are no stupid questions if you have them. Not that there's no stupid questions allowed, it's just, Anyway, next, please. So, we're going to talk a little bit about stigma and HIV. We're going to go through about probably 8 or so different things that I've heard about in the community and about from my patients about HIV and try to dispel those myths a little bit. Talk briefly about some of the complications that you can get from HIV, and as at the very end, go over some of the main treatment options that we have available. Next. So obviously we've come a long ways. We've had 30 plus years experience with HIV, and we've had a lot of successes, obviously, over the years. One thing we haven't had as much success as we had hoped is with regards to, can anybody guess?
Cure.
Cure, okay. We've had certainly some advances towards that, but not as much as we'd like.
Vaccine.
Sorry? Fatalities, okay.
Vaccine.
Adherence, vaccines, okay. All those are great answers, but the one main thing that I wanted to bring across was the number of new infections per year. And why do we think that may be?
People think that they can take medication and they're okay.
Partly, yes, absolutely. So there's a more relaxed attitude about the disease in general, right? Anything else? Drug use, so all those things play, but we'll come to the one of the most important points later on too.
What is the age of the average new infected person?
Well, we know that the highest risk group are the young patients, typically between the ages of in teenage years up to 25 or 26 or so. That's the highest rate of infections, particularly in men of color. Okay, so despite all these things, we still have a lot of work to do. I guess that's the main point of this slide. Next. Stigma. We don't talk about this as much as we probably should, right? We focus so much on treatment and getting patients to live long enough. That's a very important focus. I'm not trying to take away from that. But part of the problem that we have is this ongoing, ignorance about HIV and people being afraid to talk about it, whether it's in their families, whether it's in their church, whether it's in their group of friends, and a lot of these things that encompass stigma I think we underplay its importance in the epidemic. So as you can see, there are many. Sorry about the picture, in case you guys are science students. Stigma is also a part of a flower, but that's not the point. Next. So, it's proposed to be one of the major barriers to HIV care, HIV prevention, and all these, the much money that we're pouring into trying to take care of patients, prevent new infections, but if we don't address the problem of us just not talking about it as a community, we're not really going to make as much progress as we hope. So that's the main point of this slide, with the big rock in the road. Next. Obviously, stigma is a huge issue that affects your life in many different areas, socially, familially, whether you get a job or not, and obviously how well a patient does with his or her own health. A lot of discrimination within peers and family and coworkers, and it just rolls on and on and on. It's a big deal. Next, please. So, being that point established, we want to spend the next few slides and time talking about myth busting a little bit. I don't know if you guys seen this show. There are a couple of geeks who talk about various things and try to verify or disprove. So that's okay. So yeah. Okay.
I'm so buying you a real copy of Photoshop.
Next, please. Okay, so the first scenario we have. Click this on. Thank you. So a friend of yours texts you this message, and how would you respond? I'm so depressed. Getting HIV was one of the worst things that ever happened to me. I'm so afraid that I won't live long, and I'll probably die from this infection or one of its complications. How would they respond to that? Or whether you think it's a truth or myth? Okay, next please. Next. So yeah, and why is that so? Next please. So when we look, obviously, early in the epidemic, the ratios of death or badness that happens to a patient was a lot different. Now that we have effective therapies for our patients, things are looking a lot brighter. Patients are living longer. AIDS-related deaths are down to about 30% or so. And the rest of the complications that people actually die from are some of the ones listed there: liver-related disease, non-AIDS-related cancers, cardiovascular disease, non-natural, and others. And although some may have complications from medicines like lactic acidosis, pancreatitis, that's somewhat minimal compared to the whole spectrum of patients actually suffering from the treatment. So that's a very good example of how far we've come. So, next. Okay, the next one. About 90% of all people who have HIV infection know they're positive. What do we think about that number? You think it's true? You think it's false?
Well,
Okay, all right. So next, please. You're right. So approximately 25% don't even know they're positive. So about 75% do know they're positive. Okay, so that's probably what I was trying to get at initially about why do we think the epidemic is ongoing. All the things you guys mentioned are all perfectly valid and contribute to that process. But this is one of the main reasons, and this. Because a lot of people know intend to infect their partners, but they don't even know it, they don't even get tested. And why? Because we don't talk about it. We don't have it as a routine thing that we order and test for until very recently. So, next. Okay, monogamy. Topic. Okay. Yeah, thank you. If I have only one lifetime sexual partner, and I'm certain that my partner is quote-unquote faithful, I don't need to be tested for HIV or other STDs because I'm considered low risk. What do we think about that?
If it's true low risk, but it's never true.
Well, so yeah, I mean, the CDC has recommended, opt-out testing since 2006. So it's been kind of slow to roll out, but we're finally getting there where patients are being offered this test as part of their routine healthcare. And that's a huge step towards, I think, doing the right thing. And we're finally very happy about that. Because even when I went to medical school, which was, I like to think, not too long ago, but we were taught to only check HIV tests on patients who are really at high risk. Right? In fact, IV drug users, patients having multiple sexual partners, having unprotected sex. But we know that doesn't work, right? If they're sexually active and they have a risk factor. So especially nowadays when the testing has become so affordable and so cheap, there's no reason not to. So those are just basically high-risk groups that are outlined there, and those are the percentages of Los Angeles, actually, of patients who are positive in Los Angeles area. 18% African Americans, Hispanics 31%, women 18%. Okay, so significant now. So we talked about earlier how the younger group, age groups, particularly MSMs, 13 to 29 years old, are very, very high risk, particularly the African American population. It's estimated that there's a 48% increase in that particular age group or risk group just in the past, from 2006 to 2009. So, thank you. Next. HIV testing. So I am way too scared of needles to get checked, and the only way I get checked is to get stuck in a blood drain. That's false, right? So yeah. So how do we check nowadays?
Swab on the mouth.
Okay, good. So that's definitely one way. We have all these rapid tests, right? One of which is a very common one we use called Oral Quick, or from the company OraSure. Very easily done. It takes about 15 minutes or 20 minutes to get the result back. And as you can see here, you get one line for the control being negative, and we have 2 lines as potentially positive. Do we ever take this as a full face value and say this is a definite positive? No, right? We have to do confirmation testing. Very good. Next slide. Then one of the newer tests actually has come out, and I know some of the testing centers are using this too. Have you guys heard of this INSTI? Yeah. So it's very fast. You get the test result back in a minute or a little over a minute. But it is a finger prick spot. So here you see the negative and positive test here. So these are some of the advances that we're using. They're getting easier to be done. Patients are having to wait less for the results, so there's less anxiety, less issues with that, and they're getting cheaper. Okay? So next, please. HIV testing. Another question. If my oral quick advanced rapid test is negative, there is still a chance that I may have HIV. That's true.
True, yeah.
Right, correct. So what is that data? I think let's just take a look. So it's about 99.3% effective in identifying patients who do have an infection. So it's less than 1% that's a true, false negative, right? So you could have a negative test and potentially, very rare, but have it be a false negative. But overall, it's a very, very good test. And the InSteve, which I don't have the stats for, is even better. It's like 99.8% or something like that sensitive. Okay, so good. Next, please. Discussing your test results. That's always a kind of a sticky issue potentially, right? So if you are tested HIV positive, telling your sexual partner is the right and responsible thing to do. Okay, most people would probably agree that that is true. Although, I personally, being a provider to HIV patients, I have not had an issue with this. Most patients are willing to talk to their providers. Talk to their significant partner about this issue, but. There are occasions where that is more difficult, or there are partners that they don't know how to get in contact with anymore, potentially. So there are services out there that is provided by public health to help find those partners and anonymously notify them that they may have been exposed and get tested. So that is something that is available to our patients and to our providers who may run into that issue. Any questions about that issue particularly? Okay, great. Thanks. I had this slide in there because I don't know if you guys want to talk about it, but when you're talking about the legal system and how that affects this particular issue, it is possible to be prosecuted for if you don't notify your partner, but I think they've had like over 300 prosecutions per se, but less than 20% have actually resulted in a conviction. And as I understand it, the law is set up in a manner where it's mainly trying to address patients who intentionally go out there and try to infect multiple people's or their sexual partners, and it's designed to help prevent that. Not so much applicable to partners or patients who do not knowingly have infected somebody else. So the specific intent is very important. They have to meet all these criteria to be potentially convicted for that potential wrongdoing. Next, a question about keeping safe. I'm HIV positive, so as long as I have sex with other HIV positive patients or people, I don't really need to use condoms. Myth, right?
Yeah.
And why do we think that is? Okay, so there it is, yeah. So if we don't use condoms, we know that we don't protect ourselves from other STDs, right? Which can make your HIV control or HIV care a little bit more complicated. And obviously we can't get other strains of the virus from other people that can complicate our care, complicate our treatment options for our future. Right? So that's, thank you. Next. Another one for keeping safe. I am on treatment and my viral load is undetectable. Is it possible, or it is impossible for me to give this HIV virus to my sexual partner? Also a myth, right? So what's the data with that? Anybody know? So basically, we looked at patients who have undetectable viral load in their blood, and about close to 1 to 1.3 or 4% of those patients still have detectable virus in their semen, their vaginal secretion, etc. So the risk is very, very low. But it's not zero. So that's why we always recommend, regardless of who you're having sex with or who our patient's having sex with, always use a condom to protect yourself, protect your partner, regardless of what your labs look like or where it looks like. Okay, great. Next is, HIV is currently not only treatable but curable.
No.
Okay, how many think it's true?
Are we including the Berlin
Trick
patient?
question.
Yeah, it is a trick question, isn't it?
Are we including the
So
Berlin
I didn't
patient?
check the box. That's what. So yeah. So next slide, please. So a good example of somebody who's in the limelight and getting good HIV care and having HIV virus under good control is Magic Johnson. I don't know if you guys heard of this patient, Timothy Brown. He's one of our only, well, I won't say only right now, but one of our very, very few patients who have been cured, essentially functionally from HIV. Anybody know his situation?
Bone marrow transplant or something?
Right, bone marrow transplant. Yeah, he had leukemia. The doctor was smart enough to find a donor who had basically a mutation in his stem cells that prevented them from being infected or getting infected with HIV, and it worked so far. His virus has not come back despite being off medicines for many, many years. Anybody heard about the recent potential cure in a baby? Yeah. So in that scenario, actually, it's very interesting. The baby was born to an HIV-infected mother. They didn't find out till the delivery. The mother and the baby was given medicines, and they actually tested the baby several time points for the virus, checking for DNA, the RNA, and it was positive. So they, despite being placed on medicines, so they kept the baby on the medicines, treating it as if, like a chronic HIV infection for this baby. But just by chance that the mom, after a year and a half or so, took the baby out of care and stopped all her medicines, and they found out that the virus is gone. They couldn't detect the virus anymore despite the baby being off medicine. So that's certainly sparked a lot of interest, a lot of research ideas into trying to find a cure. The idea is that they think the virus, although it had integrated itself and infected the baby, the pool of the reservoir of the virus was small enough that the medicines for that amount of time was able to eradicate on a slow, I guess by that time interval. It just I always wonder actually if other babies were treated that way. Other babies maybe in the same situation, but we just never knew because no one was brave enough to take away the medicines, So certainly it's a rich area of interest, rich area of research. Next, please. Okay, so this next part of the talk we'll kind of go through very quickly, but I just wanted you guys to at least be familiar with some of the main complications that you can get from HIV. And I'm going to show some pictures that I hope you guys don't get too disturbed by, but they're of different types of infections. I actually didn't decide because, anyway, we'll just go on. Next slide. This is basically a little chart saying I don't know, we haven't talked much about CD4 count in viral, but that's an important concept for us to understand. CD4 count is an indirect measure of how well the immune system is doing in the face of the virus. And below 200, we consider that AIDS. But at different thresholds, you're at risk for certain types of infections. As you can see there are some things that you can get anytime, obviously TB, Kaposi sarcoma, shingles. Okay? But if your T cells are under 500, you're much likely to get repeated bacterial infections or thrush. Less than 200, you're more concerned about PCP, Candida infections, esophagitis. Less than 100, we're talking about some other types of infections like toxo, cryptococcus, etc. Obviously, that was all about different types of infections, but other complications related to HIV can be much beyond just infections, right? We can talk about problems with the heart, problems with the liver, problems with the kidneys, problems with your blood vessels in general, problems with your fat distribution, problems with bone density. So it spans pretty extensive part of your body. So, next, please. So this is a picture of normal mouth, normal architecture of the mouth. And here on the right, you see these white patches. Anybody know what that is? Thrush, right, Candida. Very common we see in patients. Next, please. This is a chest X-ray of a normal chest X-ray. You can see the heart shadow in the middle, real lucid or dark lung fields left and right. And here you have a patient with an infection of his lungs. This is TB, tuberculosis. Next.
Wow.
This could be many things, obviously, in an HIV patient, but this is also tuberculosis. Can certainly involve the lymph nodes. Okay, next. This is a picture of a normal retina, which is, or eye fields in the back of the eye here that we look through with an ophthalmoscope. But you can see a nice optic nerve there. The retina is nice and clean without any blotches. You have nice blood vessels that are clear. Here's an example of CMV retinitis, where we can see hemorrhaging and exudates. We see there. Okay. Next, please.
Wow.
This is also an example of a CMV disease in a patient, but in their esophagus. Can cause a lot of erosion and a lot of inflammation as the infection pursues or ensues. Next. Here are some pictures of, you know what this is? Close. That's right. No.
It is caused by a herpes virus.
It is caused by herpes. Thank you. But it's not the typical herpes that we think.
Not your typical herpes.
It's a tumor of the blood vessels.
Wow.
Kaposi sarcoma. Oh, I'm sorry, I missed that. Oh, good job. I'm sorry. Well, I'm the same one, that's why I didn't see it. So, yes, this is a Kaposi sarcoma. Next slide, please. This is just an example of HIV wasting. Obviously, this is a very dramatic version of it. You can have HIV wasting and lipodystrophy that affects different parts of the body, but basically, if you don't control the virus with the medicines, it obviously starts eating away at you, not just your immune system, but your body. You know, all those calories that you take in, if you're not using it to nourish yourself and you're using it to fight off the virus without the medicine's help, this is what happens over time. So, next, please. This is lymphoma. Okay, so another tumor that could be on the skin, be in the brain, as you can see from the MRI there. And it also can present with swollen glands, as we see with the other patient with the TB. Next, please. So those are some of the more common ones. But obviously we talked about complications of HIV can expand the whole body, really. And why do we think that is? And why there's so many different complications? It boils down to the next slide. It's inflammation, right? Partly, we realize that inflammation is a part of our process of our body, part of our immune system that you do to live, and we've just evolved this way to handle infections, to handle injury. It's a normal part of our healing process. Next. Go ahead and click. So when you cut yourself, this inflammation process causes the swelling, the redness, and the pain. And when you get a cold or flu, this same process causes the fever, the aches, the pains, the swelling, etc. Next. So why does chronic inflammation happen to people in HIV? Because HIV currently is not a readily curable disease, and it's a chronic infection, meaning it's treatable with medicines, but it still lingers in you and causes this chronic inflammation. And next, please. It keeps triggering your body to release all these chemicals to cause this chronic inflammation in your body, which causes your side effects for you, whether it be kidneys, whether it be your heart, whether it be your eyes, etc. Next, please. So this is a diagram of all the different organs that can be affected by the HIV virus from this chronic inflammation. If we could just go through, I think it should take dementia, heart disease, liver disease, kidney disease, cancers. Next. So what happens after somebody's diagnosed with HIV? And again, I apologize if this is stuff that you guys already know, but obviously seeking care and staying in care is a big issue, and we want to encourage that. The CD4 count, as we talked about, measures your immune system and how it's been affected by the virus. We want that to be high. The viral load, we want it to be low when you're on treatment, preferably undetectable in less than 48 copies. But there are issues, many issues, as you know, regarding HIV care that we run into, drug resistance being part of that. And that's the standard of care that we do check for drug resistance right off the bat before any patient is placed on medicines. Next. So, let's see, the main points are that we have very effective therapies that are becoming more simplified, both in terms of pills and both in terms of side effects, and with the sustained efficacy that we've seen over time. It is right now a lifelong commitment to be on medicines, but we're hopeful for a cure, and hopefully it will be in my lifetime. I really truly believe it will be in my lifetime. So hope to see that happen. Next, please. Next, please. I think we already talked about that. Okay, these are the pills. The pills each other. So these are the one pill once a day pills that we have: Atripla, Complera, and Stribild. So we've certainly come a long ways. Next. These are some of the other common regimens that we also use. 3 pills once a day. Maritazine or Truvada, as mentioned, resistant or Truvada. Next. Some of the common side effects: upset stomach, diarrhea, rash, dizziness, sleep disturbances, kidney liver dysfunction. All those things are a lot more common nowadays. Next slide, please. This is an example of some of the percentages of patients who have these side effects with some of the older medicines like Clelitra, the nausea, 70%, diarrhea, 28%. Just to compare with some of the newer medicines that we have, like Raytime or Raytripla, 4, 3%, 2%. So we've come a long ways, both in terms of pill burden, both in terms of side effects of these medicines. Next, please. So, basically, take-home points about this talk. We want to encourage us as a community to do more of these discussions, more of these events where we can talk openly about HIV, and getting people more knowledgeable and aware of it, and getting tested on a regular basis so we can get a better hold of this epidemic. And for patients to be feeling empowered, knowing that there are many good options for them out there, both in terms of care, both in terms of support services, etc. And there's a lot of hope, a lot of help out there. And living healthily with HIV is very possible and likely if we stay in care. Thank you very much. Anybody have any questions? Yes, sir.
I understand Dr. McCallum is research at USC. So what exactly do you mean?
I work with Dr. Kat actually in the same clinic.
You're a researcher?
No, well, no. I did some research when I was a trainee, but right now I'm all patient care.
Who's in charge of research?
We have another doctor, Dr. Michael Boudet, who's in charge of research at our institute.
He's the higher up there over there research?
He's our research director, yes.
So these protocols, how does that work over there at USC exactly? What exactly you suggest your own protocols, or you have to take what gives you, or what is the situation?
Do you want to answer that, Dr. Kat?
Okay, so the question is, how do research protocols work at USC? So we do research from
very different avenues. You can have researcher-initiated projects. So in other words, I can come up with an idea. Problem is, I got to go find the money to do it. So that's, if there's not grants that are out there, it's very difficult to get. The other is it comes through collective organizations such as the AIDS Clinical Trials, in which we do an awful lot of research with. And those projects and programs are developed on a very high upper level of administration that takes place. And there's other research projects.
Dr. Fauci or USC?
Specifically for the AIDS clinical trials, but they have several panels of doctors.
That's in Washington DC or Rockville, Maryland, where's that located?
And actually all those places, so they're very centered, but they try to convene. It doesn't take place in any one place since they have researchers who are in charge of different topics at different centers.
You have multi-boards doing the same thing? It's not centralized?
Connie would be able to help you with the specifics of that actually, so. I don't know if it's helpful to.
Yes, I'm interested in knowing just how.
Go ahead, Connie, so just reach out to her, she can give you as many details as
As a
possible.
person who's on the cab at that location at USC and at US, at UCLA Harbor and at UCLA Care, I'm getting fed up with all these chemical protocols. I mean, it's just one more chemical, one more pill. I'm getting tired of trading for the complications of pills. And that's what this is at this point.
Yeah, I think actually the movement is towards other venues, but we're going to take another question.
Yeah. With the Affordable Care Act coming up, are there any benefits for us POS folks that are not beyond the basic coverage, healthcare coverage?
With the Affordable Care Act, are there any benefits, you said?
Yes, besides just we'll all be able to change our health coverage without any disqualifications or just, and also just basic coverage.
Well, I see, at least from my perspective, the greatest advantage is that you won't be disallowed to enroll into an insurance program that you have a pre-existing condition like HIV. But I'm not sure if I understand the question.
Were there any provisions in the Affordable Care Act for additional research, for any other perks for POS folks?
The short answer is no. The longer answer is, not that I'm specifically aware of as a result of the Affordable Care Act, other than the fact that more people will be into care, but nothing specifically directed towards HIV care as a part of the Affordable Care Act specifically, but it's treating it as a chronic illness. The only caveat to that is, for the first time ever, we have a national AIDS strategy. But the problem is there's not a lot of money behind that national AIDS strategy. That's been a complaint that people in the field have put out there. But at least it's a strategy. So, but I'm sorry I can't better answer that. But do you know if there's anything specific? Not to my knowledge. Anybody out there know? Anybody?
But it has to do with stigma, though, right? The reason that there is not money behind it is because the people that are controlling all the money are not so interested in having a cure for it.
Well, I think that could be part of it. I don't know, politics is kind of complex, and I don't particularly care for it myself. They're not very scientific with their purpose. So,
but it does affect, even if you don't like it, it does affect the way that it does trickle down or trickle up. The money gets put where they want to get it, where they put it. And if they're not behind something, or they're not morally attached or detached from it.
If they don't have an investment in it, they're likely not to really.
Right, it affects whether they're going to give the money there or someplace else.
Yeah, you're absolutely right. If a fraction of what went for our defense spending for one day went into AIDS care, we would quadruple our budget. Yes, ma'am. This is questions for him, though, right?
So I studied at Washington University in June to cure HIV and our super Dr.
What?
I found it was pretty interesting, and I'm wondering if anyone in college or whether or not that would be something that would be taking effect.
Yeah, so the question is actually, who's doing what to study the bee venom in killing HIV, right? So the study that came from out of University of Washington was actually a basic science study. So basically, it wasn't even a clinical study, it wasn't even done in humans. But it's actually very interesting. It's that bee venom, I can't remember what bee it was, it might even been a honeybee, but we'll say the honeybee. We'll say it was some bee. Some bee with venom. The venom itself was very naturally sidled to the virus itself. They didn't explain the mechanism. I don't think they understand the mechanism why. But that is actually at a very basic level of research. So ideally, it's going to want to take a direction to where to go. And some of these things sound awesome in the beginning, and then as you study them further, it either becomes they're not as awesome because as you learn more. You know, but so that's the very, very beginning. So I was really intrigued by that study. You know, it reminds me of something a friend of mine said to me years ago. He says, wouldn't it be wild if we woke up one day and found that the cure for AIDS was an aspirin? This is an example where wouldn't it be wild if the cure for HIV was bee venom? Now, how do you sting everybody enough to cure it is actually the question.
Well, they're saying that that's the reason why there aren't as many bees around now, because they're collecting so many bees to make the studies.
No, the reason there's no bees is because pesticides have killed them. I saw the National Geographic commercial. I'm glad you're reading the stuff. Yes, sir.
Me, I support everybody have HIV because I've been walking to AIDS Walk and I just walked a sign for support APLA because I'm more outgoing and I got interviewed in TV like the last year that I did. Yeah. And I'm a very supportive person that I want to be out there.
So some words of support there. What's your name?
Frankie.
Frankie, thanks Frankie. Keep up the good work.
Thanks. I'm going to do it again.
Do it again, and again, and again. There's walks everywhere you could do, so
yes,
you can never stop walking. You could be like, what was his name? Forrest Gump.
Yeah.
Frankie Gump. Right. Anything else? Anything, yes sir.
Has Registrar developing any type of research in a combination of the THC drug in addition with assisting or offsetting the HIV virus?
No, although that research has been, we've read some posters that have been done on that. We don't have any studies like that before us right now, but I think we will see more of those. I think what he's mentioning is the uses of extracts from marijuana that actually have been shown to protect at least brain cells from invasion, dendrocytes in the brain from invasion of the virus. So stoners are onto something, I guess. Yes.
Have you heard of the Draco protein?
Oddly enough, I have, but I don't think I could tell you. Yes. Tell me about it.
I read up on Science Magazine, actually, it was like the front cover. They said that it actually attacks the virus and kills it. It destroys the protein.
Oh, right. I know what you're talking about. That's also something that's all very, very basic research to be done. One more question I think we have time for, right there in the back.
Yeah, I just wonder, would you guys be doing any clinical trials?
Yes, so we do plenty of clinical trials. You can actually find that online at ACTU. Actually, just Google AIDS Clinical Trials Unit USC.
Okay.
And you'll find all the AIDS clinical trials that we do.
Thank you.
I can't remember my own website. It's on my favorites bar, so I never remember my favorites bar. It's like I don't remember anybody's phone number now. I just have to find it in my phone. Right. You can mention it. Sure. Well, Dr. Satal, why would he say he's not a researcher? Because he's actually a PI on a current study.
This trial just opened up and it's been under preparation for a long time. It's actually using PrEP for MSMs. So I just want to let you guys know at least about it. If you're interested, please. So it's pre-exposure prophylaxis. So they're looking for patients who are not HIV positive but maybe at high risk for getting HIV, and they're giving patients Truvada. It's a 1 pill a day regimen that has relatively few side effects. It's been shown to be very effective in MSMs in previous studies called the IPREX study. They've studied it in heterosexual discordant couples also, and women. So we're now opening up a study at USC enrolling MSMs only right now, but hopefully in the future we'll have a study also looking at heterosexual couples. And that the website, if you guys, I don't know when you guys signed in, you have to leave any email contacts or anything like that. If you get interested in getting a link for that website, we can also always forward that to you too.
Do the couples have to be Zero Discord or same?
If I guess what you asked, if high risk MSMs in general, so if they're not in a relationship, if they meet a certain criteria of having like new sexual partners per 3 months, or having unprotected sex this many times per 3 months, you may still qualify even if you're not in a relationship.
Are they doing any kind of studies with Zero Discord relationships?
For
Or like say like somebody who's on meds and undetectable and somebody who's negative.
Right, so this study, if they're men and if they're in a sexual discordant relationship, they can be in this study. They would consider that a high-risk individual for acquiring HIV, and they would qualify for that. So whether you're in a relationship or not, you can qualify for this study if you're a man.
We're going to call it there. I just want to, Ted wants to mention one event that we have at the end of the year for Hollywood members.
Thank you for coming this evening. We, Hollywood members, sponsors in this program. Dr. Cadden and Dr. Satar are on our board of directors. They're the ones who created and developed these PowerPoint presentations for you. But I also want to mention the fact that at the end of the year, on December 1st, which is a Sunday, Hollywood members will be having a benefit program or a fundraiser to continue these kind of programs. So we'd love to invite you to all to the events. We will be getting flyers and equipment information out to you, and it's going to be a wonderful evening of entertainment with some fine, fantastic people. And it looks like we're going to have some people from the Hollywood Master Chorale and possibly from the LA Philharmonic performing. So we'd love to have you come and enjoy our evening. It'll be December 1st up in Hollywood, and all the information will be available to you very soon. Thank you very much for coming.
A special thank you to Chef Satiano.
Very good.
I remember you when you got your award at the West Hollywood on the plaque. It was I'm Frank. Because we have been walking at H-Walk for like 2 years. Yeah, I wear the rainbow mohawk. Yes, like I was like, yes, my dad saw it, and I just wanted to yes.